Okay, looks like it is 1 o'clock Central, so we will go ahead and get started this afternoon. Good afternoon, everybody, and welcome to our December 2023 WPS Medicare Audit Provider Webinar. So, in the past, we've tried to have these on basically a quarterly basis, and we're going to continue to do that. And this one will wrap up the year, the 2023 year. Just a few little housekeeping items as we get started. First of all, just like last time, we're going to have 2 sessions available. I mentioned that in the emails. So we have today's session, we have tomorrow morning's session, same material we're covering. The idea was to provide for a little more flexibility. Some people prefer afternoons, others prefer morning, and also eventually to accommodate more attendees. We have a cap of 1,000 per session. So we're trying to grow this, offer more coverage of various topics. So we just wanted to make sure everybody gets a chance to get in if they want to. So again, each session is the same material that we're covering. And the other thing I wanted to mention is that we will be recording this session just as we have all the way since the beginning, the first session. So the session is being recorded. I'll post it to the WPS YouTube channel, and I will send out an email including the link to the recording, the PowerPoints, again, just in case somebody didn't get them the first time, a CET or CPE attendance certificate, and a copy of the agenda. So that'll be sent out possibly by the end of this week, hopefully by the end of this week. I'll take a look at the 2 sessions, and whichever one seemed to be a better session, better quality of recording and everything, I'll send that one out. The other thing I wanted to mention here is I keep an updated attendance listing, or attendance as well as contact listing. So every time when we're preparing for the next webinar, I tried to send that email out to everybody in the list. So if you have anybody else you'd like to join or you'd like to be notified of this, please let me know and I can add them to the list. Of course, if anybody ever wants to be removed from the list, let me know that as well. So if you move to a different area or just not the topics you need to see, feel free to do that. The other thing is just a reminder, we have a survey at the end of the session, and I'm actually going to post that link right now in the chat area. So what you see right now is the link to the survey. That way you can click it from there rather than having to find it in the emails or anything like that. And we certainly appreciate you taking the chance to fill that out. We use that feedback to try to provide better information in the future. I do want to issue just a reminder. I know, of course, we have some WPS MAC staff on the call. We might have other MAC staff as well. These surveys are not to be taken by MAC staff. So they're just for providers, consultants, whoever else, but no MAC staff can take these surveys. So just a reminder there. Again, I posted that in the chat area. That's tomorrow's survey link. So now on to the agenda. So there are a few topics that come up, each time, each quarter, but there are some new topics we were going to talk about this time as well. So we have the S10 uncompensated care audits, and this one, we're wrapping up for the year, so this is going to be a fairly brief discussion. I wanted to provide an update on the Nursing and Allied Health Reopening Project, and I have that plural, and I'll explain what I mean by that, but I wanted to provide a little update on that. An update on the current DISH issues, and I will just kind of mention up front, I was hoping we'd have even more of an update, but I think we're a little bit short before we're going to get the final information from CMS, so we'll provide what we can, and hopefully in the next month or two, or certainly by the next time we have a webinar, we'll have the final information. So again, I'll provide what I can there. One of the new topics we have not really covered in any of these webinars is RHC consolidations. And what I have here is a little bit of background on RHCs, and we're going to again hit on the consolidation issue, especially with the new rates, the grandfathered RHCs. We'll cover all of that here. I wanted to bring up Certified Registered Nurse Anesthetists, the CRNA. And this is a topic, again, we haven't really covered before. And kind of interestingly, we've had a few questions on this topic over the past week or two, so it might be a timely topic. Nothing really new coming out of this, but I just wanted to bring it up as an educational issue. The same thing with sole community hospitals and Medicare Dependent Hospitals, SCH and MDH facilities, just to provide a little overview on that. And as with all of our webinars, I want to provide just a little overview of what we have out on the website, the webinars we provide, obviously this one included, and the various YouTube training resources we have. One thing I'll mention right up front, anybody that's gone to our website recently would have noticed somewhat of a redesign, actually a complete redesign of the website. The same information's there. It's just a completely different look, different organization. So we'll cover a little bit of that later. And as far as questions, one thing I want to mention is I have the chat area, a chat box open on my other monitor. So if you have any questions throughout the webinar, feel free to type them in there. Or if you wanted to speak them, you could just let me know and I can make sure you can turn your mic back on and we can talk about it there. So feel free to do that along the way. You do not need to wait until the end to ask questions. So with that, we'll go on to our first topic here. And the first one is, again, the S10 uncompensated care audits, or the charity care audits, as it's often referred to as. What I have here, a lot of this information is the same as what we've covered in the past few webinars. So I'm not going to dig too deeply into this history. I just wanted to leave it here for informational purposes. So this just goes all the way back to the earlier years when we audited it, what the information was for, when it was used. So again, I'm not going to dig deep into that. Here we have the 2020, 21, and 22 S10 audits. Again, what it was used for. The one thing I will point out is that CMS did change it, and now it's period we look at could potentially impact the next 3 years of S10 uncompensated care factors. So just something to keep in mind there. And I do also want to mention, for quite a few years now, we've been auditing 100% of the DISH eligible providers. Now, these are all acute care hospitals, of course, with DISH. We're not doing anything with rehabs and LIP or anything like that. So this is just the DISH eligible hospitals. But again, it's those that have actually reported DISH. So even though you could argue an acute care hospital has the potential to be DISH eligible, they're not necessarily DISH eligible until they've qualified for DISH. So just wanted to point that out there. So now we're on to this year's reviews. We're in calendar year 2023, really close to the end of it, and we're wrapping up this year's cycle of reviews. They're due to CMS by December 31st. So what we're looking at this year bold that because, again, CMS could always change their mind, but we're expecting this data to be used as 1/3 of the weighted average data, or just the average data, I should say, in the factor 3 calculation for the fiscal year 25 rates, which is 10/1/24 through 9/30/25. So again, that won't come out. We won't see it until April or May for the proposed rule, and then of course August generally for the final rule. But we assume CMS is going to continue down that same path. They've done it for the past few years. No reason to believe they'll change. So again, we're at the end of this year's cycle of review, and with every year, as we wrap up the reviews, we take a look at all the information, all the feedback from our auditors to see, do we have any questions that need to go to CMS? Do we have anything that we need to do differently? So we try to improve the process within the constraints and confines of what CMS requires us to do. So keep that in mind. We have, again, DISH eligible hospitals. So just to define that further, any hospital that has reported DISH on ePart A line 34, including the SCH and MDH providers. That's the key thing here. Now, that's currently the requirement. So one could very well argue that some of these sole community hospitals, they're not even close to getting paid the federal rate because their hospital specific rate is so much higher. So really nothing we do during a review would have any impact to their payment down the road. And that's a very good argument. In fact, it's actually been argued in this particular Federal Register right here. And based on CMS's response, they basically said, we are still going to review those sole community hospitals and Medicare dependent hospitals. So if they've reported DISH on E-Part A line 34, they will have an S10 audit. That's the key thing. That's the only criterion that we use. Now, the other thing about that is when we first grab our universe of reviews at the beginning of the year, we generally start that around February-ish, and we update it for the next few months. In fact, we look at it all the way throughout the year. But if a provider did not qualify for DISH initially, but then maybe there's an amended cost report for one reason or another that adds DISH in, that also becomes subject to the S10 audit. So we hope that we find all that information well before the December 31st due date. But if there was a situation where the amended cost report didn't come in until December or whenever, we just work with CMS to see the necessity of reviewing that. So just keep that in mind there. And now I do want to mention one thing here. So there's some instruction. I said that the sole community hospitals are required to be reviewed for the S10 audit. But interestingly, if you look at the S10 instructions, where you'll find the new exhibits, the new cost report templates, the 3B and 3C exhibits, they do have a piece in here. Now, keep in mind, these exhibits are required to be submitted prior to or at the time that the cost report is initially submitted. It's a requirement for acceptance of the cost report. Now, we just said we know we are required to review those for S10 audits, but interestingly, CMS here says, hey, if an SCH is eligible to receive a DISH payment adjustment, but E-Part A line 48 is greater than line 47, in other words, the hospital-specific rate is higher than the federal rates, you do not need to complete the Exhibit 3C listing at the time of submission. This rule, I just copied the 3C, but it's the exact same thing for 3B. So you're not required to submit the documentation up front. But at this point, until CMS changes it, we're still required to do the audit later on. And of course, we'll need the template at that point. So it's a bit of a disconnect. And, it'd be nice, honestly, if CMS down the road decides to cut the SCHs out of that review altogether. Because again, it really doesn't do anything to the payment. But at this point, we're required to audit that. So I just wanted to point out that inconsistency in case there's a question there. For S10, just wanted to mention we do have some information. Now, a lot of this stuff is the same links I've given you in the past. We have our WPS website. Now, by the way, these links, they'll still take you to the new website. They did change the every single webinar we've covered over the past couple of years, we've at least had a little bit of a section on S10. But these were the main ones for the S10 webinar, part 1 and part 2 a few years ago. The other thing about that is with the webinars, the first webinar of the year, which is usually late February or early March, is pretty much devoted to S10 because that's right around the time we start it. So we'll do the same thing this next year, again, late February, early March, to refresh everybody on the requirements, to inform you of any changes, and just to update the information in general. So that is what we have for S10. Now we get on to one of the topics that we've covered a little bit in the last webinar. We have a little bit more information to add to it. But for this one, I said nursing and allied health reopening projects, plural. Now, we only have one project going at this time. I mean by projects. We had the CR 11642 a few years back. We had the last one that just got kind of started and stopped before CR 13337 came about. And then, of course, we have 13337. So I want to go back to the history of the nursing allied health payment altogether because it'll help explain what we're doing in this latest project. Nursing and Allied Health as an add-on payment really started way back with CR 2692 back in May of 2003. And this one was a public change request, or a transmittal at the time. So it's available on the CMS website. I've linked that here. You can download it. And it actually, even though it's old, it's very important for this current project that we're doing right now, as I'll get to in just a bit. So the qualifications for this Nursing Allied Health Managed Care add-on payment, they're threefold. First of all, did the provider receive Medicare cost-based reimbursement in the current calendar year? Now, I want to mention something. Obviously, yes, there are some calendar year cost reports, but there are obviously many that span the calendar years. So in other words, they cover 2 calendar years. The payment is looked at individually per calendar year. So if you have a 930 cost report, we have to do this calculation twice for the 2 different calendar years that cost report spans. So that's one important thing. But again, did the provider receive that cost-based reimbursement in the current calendar year? They have to receive that. Plus, we look at what's called the 2 years prior cost reporting period, and we look at whether or not you had that same cost-based reimbursement there, as well as did you have managed care utilization in that 2 years prior cost report. So all 3 of those qualifications have to be met before you can receive this add-on payment in this current year. Now, just to define that 2 years prior, that's just a simple explanation for something that's a little more convoluted. It's the cost report period ending in the federal fiscal year that is, I'm just going to say is, 2 years prior to the current calendar year. Now, by is, what I'm saying is if your current calendar year is 2021, then go to the 2021 federal fiscal year, or actually the 2019 fiscal year, because it's 2 years prior to that current calendar year. So it's 21 minus 19. You don't even really need to look at technically the beginning or the end. Just subtract 2 years from the calendar year and then call it that federal fiscal year. So the cost report period ending in that 2 years prior federal fiscal year is what we're looking at. Now, the other thing for those 2 year prior cost reports, you might actually have a short period. So you might have 2 cost report periods ending in that same 2 years prior federal fiscal year. We would use both of them, even if it means that the total period is longer than 12 months, or, might not even be a full 12 months, but any cost report period ending in that 2 years prior federal fiscal year is used for this calculation and the qualification itself. So that's what we have there. And again, we would do it twice. We do the calculation twice if you had a non-calendar year cost report. So now to the calculation itself. And this, again, started with CR 2692, but it's been refined and reiterated in the later CRs. The first step of the calculation is to take the Nursing and Allied Health Program cost, the actual pass-through cost, divided by the total inpatient days to get essentially a cost per day, a pass-through cost per day. And then we multiply this by the managed care days specifically to identify how much additional payment makes sense to go to the managed care days. So this is the hospital's Nursing and Allied Health cost that's apportioned to their own managed care days. That's hospital specific there. And then CMS provides a factor that essentially calculates the exact same thing for all hospitals. So they have that data, they've developed a pool, or I shouldn't say pool, they've developed the data and they've developed a factor here. So this is when you divide it by that total amount for all hospitals, you identify this individual provider's share of the national Nursing and Allied Health managed care money. That doesn't mean that's how much they're going to get paid, but that's their share of all the managed care days in the nation. Now that percentage is going to be multiplied by the actual amount available for payment. The managed care Nursing and Allied Health pool, which is another CMS factor. And by doing that, these 3 steps, now you're identifying each individual hospital's share of that pool of available payment. Now, earlier I said that if you're not a calendar year cost report, then we'd have to do 2 calendar years of review. Each one of those would be prorated. Mute that here. Yeah, each one of those would be prorated by dividing by 12 and then multiplying by the number of months applicable to that cost report. You do that, and then you'd add together with the second calendar year as well. So that's how we identify the payment for that year. So that's just an overview that's been in place for a very long time now. Now, the problem is that CR was issued back in May of 2003, and even in the CR and in the Federal Register that went along with it, there was a discussion about these factors, the total amount and the pool amount being updated annually, but they never were until CR 11642 came out in August of 2020, so a few years back. That's basically reopening project number 1. And again, this one's a public CR, so we have a link to that. These reopenings were completed between September 2020 and March of 2021. And again, they just simply updated the nursing allied health factors for all the way from 2002 up through, at the time, 2018. Because that's all they had data for, they did issue later CRs that just provided, another year and another year of the factors. That was the idea. And that was really the goal all along, was every year you'd get a new set of factors. Now, the thing is, that was the main intent of CR 11642, but it also did a few other things. It updated the cost reporting references from the old 2552-96 form set to the 2552-10. And at the same time, it made a few changes to the things that would be included. So the data elements themselves were slightly revised. The other thing, and by the way, when it did that, when those new factors were updated, just by itself, that had the impact of reducing nursing allied health payments. But at the same time, they updated the GME payment reduction percentage, which of course only impacts those that actually have GME. Some providers have both nursing allied health and GME. Some might have one but not the other. So it's a separate factor altogether, but they updated those reduction percentages, which increased GME payments for those impacted providers. So that's what happened with CR 11642. And we completed those reopenings by the March 2021 date. Then about a year and a half after that, there was new legislation passed. The the Consolidated Appropriations Act of 2023 was passed, and the section 4143 is entitled Waiver of Caps on Annual Payments for Nursing Allied Health. So what this legislation did was basically eliminate what was a $60 million cap on that pool amount for calendar years 2010 through 2019. And that's the key thing. That legislation, that's the only way that cap could be removed, because the cap was put in place by legislation itself from Congress. Who could ever change that? That has to come from Congress. So that cap, I said they updated it year after year, but eventually it hit that $60 million cap, which technically was in place all the way back from the beginning. It was in the legislation and the change request, but the pool was already less than 60 million to begin with, so it really didn't matter until they started updating the pool and it finally hit a cap. So that's the thing I'll mention with the pool. Now, the other thing that legislation said was that these changes, this pool or this cap elimination, only impacted or was only applicable for hospitals that are still, as of 12/29/22, training. In other words, they had an active nursing allied health payment or nursing allied health training program, and they were still receiving interim nursing allied health payments as of that date. So they're older cost reports, but whether or not you were training back then really didn't matter. It's whether you were still training as of 12/29/2022. So to implement that legislation, because that's another important thing I want to mention, anytime legislation is passed, occasionally we'll get questions just days after the legislation's passed asking us, say, when are we going to make these changes? And the answer in every single case is we can't do a single thing until CMS issues a change request to implement that. Legislation, although it gives you a good background and everything, and it gives us a good idea what CMS will be doing, we don't necessarily know how they'll be doing it, and we absolutely can't make a movement until generally they'll issue a Federal Register final rule and then a change request. So that's a little bit of a side topic, but I just wanted to bring that up. So to implement that, there was, first of all, a Federal Register, and then there was the change request 13122, which was issued March of this year. So or 9 months ago, approximately 8.5 months ago. Now, again, that updated the pool factor. That was the key thing with that. And that by itself increased all nursing and allied health payments, because that's all you're doing is just updating that final multiple or multiplier. So that increased nursing and allied health payments. They did not touch the GME reduction. They didn't revert that back. So the providers in those cases kind of got the best of both worlds. Now, these were initially supposed to be completed by December 28th, and that was the goal. Everything was set up. We were going through these, and we got about a quarter of the way through, I'd say. And then another 2024 IPPS final rule was issued, and it changed that a little bit. CMS kind of reinterpreted, or they took a look at that legislation more deeply, I guess, and they felt that they needed to do a little bit more than just increase the pool. So the rule here, when you look at the legislation, if you dig into it, it basically says that the overarching intent was that any money that was removed due to the changes between CR 2692 and these later CRs basically needed to be reverted back. So we're reverting back to the methodology of CR 2692. Now, the way it was done, just through the legislation, through the final rule, it was a bit convoluted. So it's not just simply, hey, let's calculate it under 2692. I will say, yes, that is the final result, but we had to go about it and basically show the comparison. That's a very simplistic way of saying it, but we had to calculate it under the CR 13122, under the CR 11642, and the old CR 2692. And again, in every single case, the 2692 is going to be higher than it would be under any of the other calculations. Now, keep in mind, so basically, if the pool factor limit removal, in other words, if the new updated pool didn't fully restore any money that was pulled back from that CR 11642 reopening, then the way it's written, the additional amount will be added into the current reopenings to get you back to what you would have had under CR 2642. That's the way it was written. So again, that's only for those hospitals that are still training nursing and allied health and receiving interim nursing and allied health payments as of 12/29/22. So it looks like we have a good question here. Does the final rule for 2024 authorize the reopening of cost reports beyond the 3-year reopening period? And the answer to that one, unfortunately, is no. That 3-year reopening requirement is still in place. So even though one could argue that those earlier years were impacted by the fact that the pool figures weren't updated, then we cannot reopen those. Now, the other thing I'll mention, though, keep in mind when we reopened for CR 11642, we took a look at everything that could possibly be reopened. In fact, we did it as early on as we could to grab every possible provider to put them into that group. The way it was issued, day by day, there were a few providers expiring from that 3 years. So we tried to get them as early as possible. And if they were reopened in CR 11642, that's not yet been 3 years, so they were certainly reopenable now. But keep in mind, even those that were missed early on, let's say 6, 7, 8 years ago, those would have been recalculated, or those would have been calculated under 2692 rules to begin with. So let's say even if we could go back and reopen older years, the calculation would essentially be the same, because what we're doing right now is putting them back to the CR 2692 rules. So in a way, it's kind of a moot point, barring any potential for, was there newer data at that time? Were there newer cost reports that could have been used to calculate that? Or maybe they were not eligible at all when we first did it, and now all of a sudden they would be eligible. Of course, there are those issues that reopening older cost reports might have been beneficial for. But the short answer to your question is no, there's nothing that has trumped that 3-year reopening requirement. So good question, though. So now we are in CR 13337. This one was issued on September 15th. Again, there's the link. These reopenings are required to be completed by March 19th of 2024, and we're making our way through those right now. So the purpose of this change request, first of all, was to stop the old reopenings from the 13122, and it implements that final rule in conjunction with that legislation and the slight changes in that legislation. So I kind of went through the details here. The actual calculation goes through a multi-step process, and the CR itself is pretty. As CR 2692 was. So we're comparing the three just essentially to prove that. And again, that's a simplification, but that's the final result. So the CR 2692 rules result in a higher payment. Rules and factor, I should say, result in a higher payment. Now, there are a few issues to note with that CR 2692 compared to, for example, the CR 11642. The outpatient pass-through costs from D Part 4, column 13, line 200, they are not part of the calculation under 2692 because they were not added in until CR 11642. Same thing goes for the labor and delivery days, S-3 Part 1, line 32. They were not added in until CR 11642. And I'm going to jump to this last bullet point first. There's one little clarification here. There was a clarification from CMS that we were to be pulling that out. So basically, virtually all of the nursing allied health payment calculations way back years ago, they did have that SNF pass-through cost excluded. So we have to follow suit now, because the overarching requirement is essentially whatever methodology was used by a particular MAC to calculate the payment under that original CR must still be used in this CR, basically to get them back to where they were. Now that takes me to this third bullet point. It's not just simply saying, hey, grab the payment amount and give them exactly that amount back. It's all about the methodology. So we have to use the same methodology. There are situations where those 2-year prior cost reports might have been reopened over the years, even after that one calculation was done. So there's a possibility that some of the data itself had just naturally changed. And now that we're looking at those cost reports, we're supposed to be grabbing the most recent version of each of those years' cost reports. So for that reason, the calculation we do now under the CR 2692 methodology may still result in a slightly different payment than what was initially paid years ago, but it's under that methodology. That's the key thing. So that is what we're essentially going through right now, doing all those calculations that are due by March. And there is more information on our website. You'll notice here, again, the link. This is the newer, domain for the website. It's the address. It's med.wpsgha.com, but you can still type in the original one and it'll take you there. I guess one benefit is that the ending part of the link is much shorter than it used to be. So it doesn't really tell you much, but if you click on that, it'll get you to that particular article. And we also have our calculation. We put a calculation out there for providers to use so you can predict what the payment's going to look like if you want to, or you can just wait till we send you the calculation there. But again, we're going through those, barring any other legislation or barring any other changes. We will have those wrapped up by March here. Now, again, since that impacted up through 2019 only, that really doesn't impact any, or shouldn't impact many, I shouldn't say, current final settlements or audits, because virtually all of those are past the 19 year anyways, unless one was on hold for some reason or a audit that had been deferred for a while. So that's a good thing. Again, barring any congressional changes. So that takes us through the nursing and allied health payment issue. Again, if there's anything else that comes out, we'll certainly update our website and our YouTube channel for that. So now on to the DISH issues. Now, again, this is one I'd hoped we would have a lot more information to provide right now, but CMS is still working on finalizing some of the requirements, I guess. But what I wanted to do is break this into two basic portions. We have the SSI ratios, which right now these are the biggest pieces that are on hold for a lot of things, hopefully soon to be released. But we have the SSI ratios, including Medicare Part C issues and just general realignments. And then we have the Section 1115 waiver day issue for DISH Medicaid days. And there is quite a bit more discussion on this in this year's IPPS final rule, fiscal year 24 IPPS final rule. And mainly we're focused on the low income pool. There are a variety of terms for it, but it's referred to as a low income pool type Section 1115 waiver day. That's more of a retroactive issue, because in this final rule, CMS did say those will no longer be allowed from 10/1/23 and after. So, but we'll get to that in just a bit. So here we have the SSI ratios, the Medicare ratio or Medicare proxy, as it's sometimes referred to as. And, we've had a lot of different issues over the years on this particular topic. The idea here, the general rule, is that the SSI ratio is calculated by taking those patients, or the days for those patients, entitled to both Medicare Part A and SSI, Supplemental Security Income. So they have to be entitled, and that's the key word there, by the way, is entitled, not paid or covered, entitled to both of those programs, divided by only those patients, I shouldn't say only, those patients entitled to Medicare Part A. So it's basically the same as the numerator, except you don't have to be entitled to SSI to be in the denominator. So out of all the patients entitled to Medicare Part A, what percentage of them were also entitled to SSI? That's essentially what that means. So the questions we have here that have been in various court cases and appeals over the years are essentially, what about the Medicare Part C days? We're talking Part A here, and now we're saying Part C. So the question is, does this count? It's not paid by Part A. It's a replacement for Part A and Part B, essentially. So what about those? Further, what about exhausted benefit or non-covered days that are also not paid? The point that was brought up in various appeals over the years, and led to CMS changes years ago was that the patient is still entitled to Medicare Part A, even if they're now Part C, if they're now paid by Part C, or even if they have exhausted their benefits altogether, they're still entitled to Part A. They don't give up that entitlement. They don't lose it, even if they're not paid under Part A. The legislation never said paid or covered. It said entitled. So that's the key thing here that led to some of these questions. We'll dig into this a little bit more in just a bit. But the Medicaid ratio is the other side of the disproportionate patient percentage. And for a Medicaid ratio, we're looking at those patients that are eligible for Medicaid. Notice the different word, eligible versus entitled. They're eligible for Medicaid, but they are not entitled to Medicare Part A, because if they were entitled to Medicare Part A, they might be up here instead. So they cannot be dual eligible. They can't be eligible for both. Just Medicaid divided by total patient days. Notice it's a different denominator altogether, so they're completely different fractions. And so the other thing, the issue that we'll talk about later is, what about those Section 1115 waiver days that are really not fully Medicaid? They're not your standard traditional Medicaid, but it's a demonstration type program. And in many cases, CMS has said, we'll treat these like Medicaid days, but we have one particular type, those low income pools, that is at the heart of a lot of the discussions and a lot of the appeals that we'll get into just a bit here. So first, we're going to focus on the SSI. I just wanted to define the two to show the distinction. But now we're going to look at the SSI, and we are looking at, first of all, different time periods. So we have discharges prior to 10/1/2004. The rule at the time, again, before those appeals, was that only covered days, or those that are paid by Medicare Part A, are included in the SSI Medicare ratio. Everything else might be in the Medicaid ratio, but not in the Medicare ratio. You know, at that time, with those rules and policies, there was really no discussion of Medicare Part C. That didn't come up until later. But after a variety of appeals, CMS issued a ruling, the 1498, well, there was R1, but then there was R2 specifically that focused on this. And it essentially said those exhausted benefit days, yes, they're still entitled, even though they weren't paid by Medicare Part A. So at that time, through that ruling, they gave providers the benefit of a choice. Do you want to use total days, again, including the exhausted benefits, or do you want to stick with the old rule of just covered? So again, the policy was, it wasn't really vague. It just said covered before, but the appeals basically said, well, that's wrong. So they gave providers the benefit of the choice. It noticed that it left Medicare Part C untouched. It was just related to this exhausted benefit days. Again, total versus covered. The difference is exhausted benefit. There were a couple CRs that came out around that time, 9311, and then I keep forgetting changes. It was 10484. That's what the providers could have seen. And this gave the providers the election, the total versus the covered. And at the same time, they also brought up the whole issue of realigning. So realignment is just simply, instead of taking the federal fiscal year period and using that period to gather an SSI ratio, a provider could always request to use their cost report period instead. That's the entire concept behind realignment. You know, using that, sliding that different period, essentially. It's still generally 12 months, but it's a different snapshot of time. It may benefit you, it may not benefit you, just kind of depends on where the days fell. So this CR, you know, that was another one years ago that we started working on, but it got put on hold, and really for two reasons. Part of it, main part of it, was the Medicare Part C issue. You know, I'm going to throw out the name of this case. It's just commonly referred to as the Alina case. That's actually a provider group, but they were the main provider group in that case. So all of these Part C days, generally are just referred to as ALINA type issues or ALINA-like issues. So that put this on hold. That put the remainder of the 9311 change request on hold. Now that's been resolved, essentially, or very, very close to being resolved. Let's put it that way. So now let's move forward to 10/1/2004 through 9/30/13. Due to those earlier appeals, CMS issued a proposed rule in 2004 and then a final rule in 2005. And this basically removed that whole coverage requirement from the Medicare SSI ratio. So it brought it back to entitled, as arguably the intent was all along through the legislation. So the exhausted benefit days are included in the Medicare SSI ratio. They've been there ever since these SSI ratios have been posted. Now, the other piece about this was that in the proposed rule, they initially proposed to keep those in the Medicaid ratio, but due to clear public comment, they decided, no, I guess they belong in the Medicare SSI ratio. So there was persuasive public comment. So that's the whole exhausted benefit side of things. Now, notice that's, again, that relates to coverage. Do they count or not because they're not technically covered, but they're entitled? The other very similar issue is Medicare Part C days. They are also not covered, but they're still entitled. It's the same underlying concept, but they were handled differently, and the way they went through the proposed and final rules was different. So CMS again proposed to put those in the Medicaid ratio, but then in the 2005 final rule, they finalized them as part of the Medicare SSI ratio. That's what led to this ALINA case. Actually, the cases, there were multiple appeals on this issue. The appeal was due to that final rule not being a logical outgrowth of the proposed rule. There wasn't the same public comment as there was about this first issue. So that's what led to the appeals that have been going on for quite some time. Now, that final rule, for that reason, was vacated in the first 2017 ALINA decision, just that part dealing with the Part C days. And CMS knew they were going to continue to appeal this up. For that reason, right when this was issued, there was a requirement for all MACs. Actually, it was before this, but there was a requirement for all MACs to issue notices of reopening for any possibly reopenable cost report dealing with Part C days, or really anything with DISH, period, because it could be impacted by Part C days. The idea was to protect the reopening rights for when this finally did get settled. We would be able to reopen those, because otherwise, once that 3 years is gone, they'd be out of luck. Whether it helped or didn't help the provider, it couldn't be touched. So those are still open. They've been reopened. They're just sitting there as they've been for a very long time. Fast forward several years, we've had multiple rounds of court cases, multiple Supreme Court cases on this issue. And the most recent ALINA Supreme Court decision from 2019, the court agreed that CMS basically made a mistake in how they handled that proposed and final rule process. They should have reproposed it, if you will. If they were going to change and there wasn't enough public comment to support it, they should have reproposed it and then had a final rule tying to that. That's the proper way to do it. So CMS, or the Supreme Court, essentially remanded that back to CMS to do a proper notice and comment rulemaking. So that's the only thing the Supreme Court really said at that point. That was the final decision. They did not say whether or not that belonged in the SSI ratio or the Medicaid ratio. In fact, they basically deferred to CMS and the Health and Human Services as the experts that would be best able to decide on that. But they need to do it properly. That's the key thing. So in August of 2020, there was a proposed rule on Part C days. And this proposed rule basically said, due to the Supreme Court decision, we're going to do a proper notice and comment rulemaking, but they did it retroactively, which is generally, it's a rather rare thing, and they have to have support for it and justification. So they included their justification in that proposed rule, why they were going to go all the way back to the beginning of DISH with that rule. So the proposal was to include Part C days in the Medicare ratio all the way back as they currently are from 10/1/13 and forward through their own proper notice and comment period. So 10/1/13 and on, they don't have quite that same issue. That was more properly done. So that's the proposed rule. There was another Supreme Court case on the whole exhausted benefit side of things, and it basically strengthened the definition of that whole entitlement to Medicare Part A requirement. This Supreme Court case didn't address Medicare Part C, but again, it's the same root cause. It's entitlement versus coverage. So this strengthens CMS's argument, so they believe. And actually, yeah, same thing. This is just more detail on that. And jumping forward here. So basically the final rule in June of 2023 did what they proposed. They did retroactive rulemaking back to the beginning of DISH. They brought in the discussion of all those Supreme Court cases, and they now the SSI ratios they believe they properly reported Medicare Part C days. Keep in mind, they've already been in there, certainly as far back as 2004, 10/1/2004. They've been in the posted SSI ratios thing. All the SSI ratios that we see on the website, they already have Medicare Part C. They were already finalized with Medicare Part C. So what this basically means is there shouldn't be any cost report settlement changes due to this final rule, because that's what CMS has been doing all along. But what does this mean? First, again, nothing until CMS issues a change request to implement that final rule. That was what I hoped would have been issued by now, but it's not, at least as of yesterday and so far today. I'd certainly know about that very quickly once it was issued, but they have not issued it yet. Once they do issue it, whether it's one or two different change requests on the different topics, we won't know until it's finalized how they decide to split it. Essentially, we believe that, first of all, that CR 10487 or 10484, those SSI realignments, those would start rolling again. Those are all pre 9/30/04. They've already been reopened. They're just sitting there now. Any older SSI realignments that CMS has not issued, we obviously expect those to roll again. And one of the other big things is the 10/104 through 9/30/13, those ALINA reopening cost reports. They'd have to be finalized or handled, I should say. Now, there could be two ways they could go about it. They could just issue a notice of closure to that reopening because arguably no change is needed. But what we suspect is going to happen is that we would have to do a zero settlement reopening, because the Supreme Court decision talked about establishing new appeal rights, and that can only be done through a reopening. It can't be done through a closure. So we suspect these will be zero settlements, but again, until CMS finalizes that, we really have no way of knowing. So the one thing I do want to mention is, there are a lot of different things coming out about the same time. We don't know how CMS is going to split it, when they're going to issue it, what the due dates are going to be. But this is absolutely a lot of work. So it's not something where once CMS does release this, providers should not expect this all to be done within a month. It's absolutely not. It's going to take quite a bit of time. So just wanted to put that out there. So let's see, I'm going to go over to the questions to see what we have now. Do we have a potential date for when the CMS DISH portal will be operational again so that we can request SSI determinations? So I guess I'm not even sure. So you're talking even later than 2013, right? I was not even aware that was down. And it's possible that it might be related to this. They might be working on something and they decided to take it down while they're prepping for this. Yeah, unfortunately, I don't really have any information on that piece. I'll certainly take a look and I'll ask some of our specialists to deal with the realignments if they're aware of anything. Oh, okay. So I bet you that might be what's going on, that they're just waiting. Oh, okay. Oh, thank you. Good point. So yeah, I'll let everybody know if we find any information out, but I'm not aware of anything right now. And yeah, Conrad, this video will definitely be posted on our WPS YouTube channel. And the next email you get from me will include the link to that. And let's see. So the next topic I wanted to bring up, now this slide actually goes with the next topic, but it comes up for a lot of different issues. CMS has reiterated this over time, over the past year, certainly for a few different things. But there's a regulation at 405/1885 that basically says a change of legal interpretation or policy by CMS in a regulation, ruling, or other interpretive rules, whether made in response to judicial precedent or otherwise, is not a basis for reopening uh, under this section. So, in other words, just because there was a court case that forced CMS to change their policy, that doesn't necessarily mean that can be a basis for going back and reopening. That's kind of what it boils down to. And again, it comes up to this next one. This is where it really becomes important. For this whole Section 1115 waiver days issue for the low income pool, there's another public change request, 12669, that is found. It was March 16th is when it was issued. It's found at this website here. And essentially, due to a variety of appeals, there was a CMS essentially said, yes, these low income pools will allow them for the currently open cost reports, or if there's a valid appeal for that issue. But based on that paragraph I just mentioned a bit ago, this change is not allowable for reopenings. So we cannot reopen for this issue. And if a cost report was reopened for something else, even DISH, we can't stick this change into it. It's not something that can be brought in through a regular reopening. It can be brought in through an appeal, but not a regular reopening. So that's the piece I wanted to mention there. Now, if it's not final settled yet, the provider has the ability to amend the cost report to include those new Section 1115 waiver days up to the point of the desk review audit begin date. So that's Section 1115 waiver days and other issues. That was stated in that CR. But if the desk review or audit has already started, you can only amend the cost report for the Section 1115 waiver day issue itself. Now, the other thing about that is the earlier the better, certainly for those amended cost reports. That way they can get them in before they start doing the audit, or at least before they get too far into the audit. The other important thing here is that it's not just simply amending and changing a number. There must be support, separate support for those 1115 waiver days. They have to be separate from the traditional Medicaid days. Otherwise, it will be denied. That's in the CR itself as well. As I mentioned, that change, CMS had to allow it due to the appeals that they lost. But in the 2024 final rule, first they proposed and then they finalized that these low income pool type days are no longer allowed 10/113 and after. The other more standard 1115 waiver days are still allowed, but those rather unique low income pool types that some states have are not allowed anymore. And actually, this doesn't relate to the Medicaid ratio. It's just DISH in general. As I said, it's unfortunate that we didn't have anything more issued from CMS by today. But as soon as they issue it, we suspect it'll be public anyways. But we'll put any information we have on our website, and most likely put a YouTube channel out there, or a YouTube video out there as well. So it's all a question of when it gets issued and what it really says. So that takes us right up to halfway through the discussion here. The next topic we have is RHC, Rural Health Clinics. This, again, is a topic we really haven't covered in the webinars before, but the idea here for a RHC, they're reimbursed on a cost per visit methodology, sometimes referred to as the all-inclusive rate. So it's not a payment, a prospective payment per discharge like PPS, anything like that. It's cost per visit. So to calculate that, you take the total costs divided by the total visits, and then multiply that by just the Medicare RHC visits. Now, I will mention here, we have covered productivity standards, I think even last time. Floor, that's that productivity standard, unless, of course, you have an exception for it. When the total visits, the denominator is increased, that spreads the total cost out over more visits and obviously decreases the cost per visit, which means less reimbursement overall. So that's how that factors in, that productivity standard. So that's its own little limit, if you will, that productivity standard, completely separate from the cost per visit limit that is the main focus of our discussion. So two completely separate things. They impact the math differently altogether. Now, this cost per visit in general is subject to a national per visit limit, and it's updated annually. All of this takes place in the cost report on worksheet M-3, which I have a screenshot of in just a bit, actually right here. This is just a random cost report I pulled up. You'll notice here on M-3, when you get the adjusted cost per visit, which now there were, I gave you the simple version of it. There are a few different adjustments to the costs and the visits, but it boils down to a cost per visit. So $919. But the limit for this year and for this year basically was apparently $693. And then the next calendar year was $707. So even though they had a cost per visit of $919, they're capped. So that's the amount that's going to be used as that cap. And then, of course, it's multiplied by the number of Medicare visits, and that's the reimbursement. Again, that's a bit of an oversimplification, but that's the basic math behind it. And M-2, by the way, is that productivity standard. So whatever number of FTEs you have multiplied by the normal productivity standard, that's your minimum number of visits. This provider here was apparently approved for an exception or an exemption to the productivity standard. Again, separate thing altogether. Now, I said generally a provider is subject to that cost per visit. There is an exception to that for those providers that are those RHCs that are provider-based to a hospital with fewer than 50 beds. Now, that's the key thing. The bed count is coming from the hospital itself, has nothing to do with any beds or anything in the RHC, if there were some. It's all about the number of beds in the hospital. If they have fewer than 50 beds, they're exempt. That RHC is exempt from the national limit, and they would be allowed to use the full cost per visit. Again, even if they're exempt from the cost per visit limit, they may still be impacted by that productivity standard issue. It's a separate piece of the calculation. Now, this is also a simplification. This is the standard way to be exempt from that cost per visit limit. There are some alternative ways that are fairly obscure. They're fairly rare, but we have an article on our website about that. So feel free to check that out if you think you qualify for a different exception, even if you have more than 50 beds in the hospital. Now, the main topic I wanted to talk about today, I gave you a little bit of a background to kind of build up to this, to show you why it's important. But the main topic was consolidation, especially under the new legislation, the new rules. Many hospitals have more than one RHC that is provider-based to them. Now, generally, each one would require its own first of all, its own line on worksheet A, its own cost center, its own worksheet S-8, which is the control questions driving that RHC, and they would each require their own M series, M1, 2, 3, all the way through. And of course, because you have those different worksheets, you would have the extra documentation needed to support that. So the consolidation issue is simply taking multiple RHCs and reporting them as one large RHC. You don't have to have a separate M series, none of that. It's all bundled together for cost reporting purposes, but you'd still have a separate provider number. You'd still bill separately. It's just a cost reporting mechanism for administrative efficiency. Now, the only real requirement here is that you must elect this consolidation in advance of the cost reporting period. That could be a day before, that could be months before. It just has to be prior to that cost reporting period beginning. And if you decide to switch and fragment, so split it out, go back to non-consolidated, you have to elect that as well. So you basically have to elect to turn it on, elect to turn it off in advance of the cost reporting period. That's the general requirement. And here, this section 80.2 is where that requirement is found. Notice this red text is the new text that was just updated earlier this year. But really, again, it just says they have to elect it in advance. We'll come back to this piece in just a little bit. This is about the new change. So worksheet A, line 88, this is where the RHCs are recorded. Now, notice that I'm excluding the FQHC discussion. There are a lot of similarities, but there are also differences between the two. Our focus here is on the RHC. And we'll talk about that. S8, line 13 is the control question for the consolidation. So it says, is this a consolidated cost report based on that provision we just looked at? If yes, then in column 2, enter the number of RHCs that you're consolidating. By the way, the old rule was basically all or nothing. The old rule, if you had 5 RHCs, you would not be able to say 3 of them are consolidated and 2 are freestand, or 2 are separately stated. It was all or nothing before. And in fact, there are edits in place that we'll get to in just a bit. Every single RHC you have must have its own worksheet A, line 88 subscript, as well as its own S8 and its own worksheet M series, which is what we're getting at right here. Now, just to give you a breakdown of that M1, we talked about S8. It's those control questions on productivity standards, consolidation, and just basic information for the RHC. M-1, it looks very similar to a worksheet A, a trial balance. Keep in mind, worksheet A just has one line for a particular RHC. Every RHC, again, would have its own line, but it's just one line of the total cost. M-1 breaks that down further to show what types of cost were in that RHC. We'll see an example of that in a bit. M-2 we actually looked at a bit ago with the productivity standard and the visits. M-3 we looked at as well, deals with the cost per visit calculation and the eventual settlement. Here's M-1. The costs that are reported on that line 88 of worksheet A are now detailed to explain what types of costs they are, as well as any reclassifications or adjustments. So that's all M-1 is. Now we're getting to the new change. And this is the Consolidated Appropriations Act of 2021, which I think that's what your question's related to. Now we're getting into that piece of it. So the Consolidated Appropriations Act of 2021, again, here's a link for the MedLearns Matters article that discussed it. They basically said, now, effective 4/1 of 2021. Due to when this was issued, they couldn't do it just a few days later, so they waited until April 1st, and they established a new payment limit per visit over an 8-year period. So it started off at $100 per visit this year in 21, and it was updated all the way through 28 so far. So that's the new limit. Now, again, those new rates apply to all new RHCs. So by new, we're talking about those that are established on or after 1/1 of 21, which again, it's a little bit unfortunate because we have this 1/1/21 date for the establishment, but none of those new rates come into play until 4/1 of 21. There's that little bit of delayed impact. So we have those new rates for new RHCs, newly established, but you might have a situation where you have old RHCs or existing RHCs, grandfathered RHCs, and if as of 12/31/2020, if you're in a hospital with less than 50 beds, and again, it's already established, so it's grandfathered. You're exempt from that limit, that national limit that we just talked about. The key thing about this, though, is it's not a one-time type of thing. If you had less than 50 beds in 12/31/2020, but then later on you go above the 50 beds, you now revert to the national rates. So the grandfathered status, in order to keep it, you have to stay below 50 beds. Now, here is one of the questions that has come up quite a bit over the past year or so, and I want to point out the actual Federal Register that addresses it. There, of course, there's a fear of losing that grandfathered status. For those providers that are getting cost-based reimbursement, they don't want to revert to a potentially lower national rate. Just changing an address, just moving, or even changing ownership does not result in losing that grandfathering. That's a common question, and page 65203 of this particular Federal Register very clearly addresses that. So that's a good thing. But the key thing, and I do want to specify this, it's the type of change of ownership where you accept the provider agreement and accept the provider number. If you change the number, that's a change in certification. That's a new facility. So that's the key thing. You have to stick with that same number. That's essentially what keeps your grandfathered status. Now the 2021, how do we calculate the payment limit for 2021? Now, when I said they're exempt from the national limit, they're exempt from that newly developed national limit, the 100 all the way through 189. They still have a limit per se. They're not free from the limit anymore like they used to be, but now the limit is cost-based, or quasi-cost-based, if you will. There's a calendar year 2020 base year cost per visit that's calculated again at the final settlement of that 2020 cost report, and it's multiplied by a 2021 update factor. So it's the greater of that, or if for some reason the national rate was higher, then of course that would be the one. That's probably pretty rare. Most often the cost per visit calculation is higher, but that becomes the limit going forward, and every year it'll be updated by the Medicare Economic Index factor for that year. If there was no cost existing in 2020, keep in mind the facility had to exist in 2020 to be grandfathered at all, but maybe you just didn't have any cost. Maybe you just barely opened it up. Let's just say 12/30 or 12/31 of 2020, you opened it up, but you haven't provided any services yet. In that case, the next year, 2021, becomes the base year with which we'll calculate this. So that's all detailed in that MedLearns Matters article. So, we're talking about the change, the Consolidated Appropriations Act, and how it set those new rates up, those new limits. But the biggest question that has come up is, how do we handle consolidation under these new rules? The big concern here, as I said, historically, that's always been an all or nothing type situation. Either everything's consolidated or nothing is. The problem is, what if you have a provider that they already have, let's say, 5 RHCs, they've been around for years, so they'd be grandfathered potentially. But now you have that same provider opens up 3 more RHCs in 2022 sometime. Now you have some that are grandfathered and some that cannot be grandfathered. Consolidating them would be a bit of a concern because really whichever way you go, do you consolidate them all as non-grandfathered or do you lump everything as grandfathered? And neither answer is really correct. In the proposed rule in 2022, this was the physician fee schedule proposed rule, by the way, the calendar year 2022, the CMS proposed that they would no longer allow new RHCs to file consolidated cost reports for that very reason. There was that concern. And that was found on page 65202 of that proposed rule. In final rule that came out later that year, they then decided to kind of go against the historical all or nothing requirement. And they said, we will still allow you to consolidate, but it has to be 2 separate consolidated groups. That's found on page 65204 of the final rule. So what that means is you might have a group of consolidated grandfathered facilities. They take up 1 line of worksheet A, and then you might have a group of consolidated non-grandfathered facilities, new facilities. They take up another line, and they'd have their own M series, their own S-8, all of that. So now there is an edit that I'll get to in a bit, but it doesn't prevent you from doing it. That was something that was changed a little bit over the years. It's what they call a serious edit, but it's really not all that serious after all. We'll see it in just a bit. So the question here for 2020 and 21, if that was the year that was used, it's calculated based on a base year, and then it gets inflated with some factor going forward. It's the same idea here. So if a group, and this is a quote, by the way, from a technical direction request we sent to CMS asking for guidance on how to do this. And they said that if a group of consolidated RHCs are grandfathered, their cost-based rate should be established as a consolidated group, which makes sense. It's essentially, it ends up being a weighted average of all the rates that each individual RHC would have had. They said since it was consolidated already before we started calculating this, there's no information to even calculate a separate rate anyways. So we can calculate a consolidated rate. And again, by doing that, we take the total cost for the entire consolidated group divided by the total visits for that entire group, and that becomes the consolidated cap that gets inflated forward with that factor for every subsequent calendar year. So that makes sense. That's no problem. But the problem is so I said it's no problem if it stays the same. But the problem is if it doesn't stay the same. So let's say, that clarification, it assumes they were already consolidated and they're going to stay consolidated. That's a perfect situation. No problem. Makes perfect sense. But let's say the provider was not already consolidated at the time we grabbed the data. They decide to consolidate after the base year cost report is calculated. What we suspect we would have to do there, since they weren't consolidated initially, but now they are going to be consolidated, we can go back and recalculate a consolidated rate as if they were consolidated all along. That's not really a big problem, although we need CMS to kind of clarify that for us. A bigger problem is if they were consolidated initially and then they drop consolidation, they fragment after the base year cost report. Because keep in mind, we don't have any individual data for that base year with which to calculate an individual rate. So what do? That's the biggest question we have for CMS. They haven't said you can't drop consolidation. They haven't prevented it, but it causes a big problem when that happens. We don't have the data to get a rate for each individual provider. And then, of course, you might even have a situation where some of the RHCs have terminated. They were in a consolidated group. Now they've terminated. Well, what does that mean? Do we still use that rate that might be tainted now? Or do we have to find a way to calculate a rate without that terminated RHC? Again, we don't know. These are questions we've asked CMS. We assume that in each of these cases, we're going to have to recalculate the base year cost report. But again, in some cases, we just don't have the data. So that's the question that's out there. We have not yet received the information, the response from them. So I'm going to take a look at the questions here. Let's see, can a hospital-based RHC consolidate? So let's assume the hospital is under 50 beds. They are receiving the cost base plus the inflation factor. And then there's a newly certified RHC that's receiving their normal rate. Yeah, so and they want to consolidate under one of the newer all-inclusive, typically reduced rates. So I think I answered that question. It would be a separate group. The grandfathered ones versus the newly certified, they'd have to be separately consolidated. So hopefully that answers that, but let me know if it was a different twist on that information. And this just reiterates what I was saying there. You'd have one line would be rural health clinic grandfathered, one would be non-grandfathered. And here's the other thing about that. They didn't really say that if you grandfather one, or I'm sorry, if you consolidate one of those groups, they technically didn't say you have to consolidate the other group. So I suppose there could be an even more unique situation or a more confusing situation or complex situation where maybe you grandfathered or you consolidated all the grandfathered units, and maybe you didn't for some reason consolidate all the non-grandfathered units. Not sure why you'd want to do that since they were paying the same rate anyways. It might be the other way around. You consolidated the non-grandfathered units, but you did not consolidate the grandfathered units. I suppose that situation could come up. So here's the thing about that, and I think this answers this other question. There is a serious edit. It's an HFS serious edit 704 that basically says, hey, if you have a consolidated report, if you answered S-8, line 13, column 1 as yes, you should not have any subscripts on line 15. But again, that could happen. We can have those subscripts. And by the way, S-2 I didn't talk about. Line 15 is where you first report the RHC to begin with. Now, again, if we have some grandfathered, some non-grandfathered, we're going to be having subscripts. So this serious edit does not block you from anything. It doesn't block you from submitting. It doesn't block us from settling. It's just a reminder that they use that word serious, but it doesn't always mean serious. And we really hope CMS changes that because now it's going to be quite common, we think. Now this serious edit, which is a different one altogether, and this is also a CMS edit, 13450S, it says if S8 line 13 column 1 is no for a particular RHC, that's the consolidation, then line 13 column 2 must be blank, which is the number of units you're consolidating, and line 14 and any subscripts must also be blank. Now the point about this is if you have two separate RHCs on worksheet S-2 and worksheet A, again, each of them has their own S8, and that first serious edit does not prevent that from happening. But within each S-8, you're going to have to report that S8 properly. In other words, for that one RHC or group of RHCs, if you're answering no, it's not consolidated, then it makes no sense to put a number of units you're consolidating. That's just a logical issue. So this is a slightly different one. That's the only reason I'm bringing it up. And this one, it does need to be fixed because it's just flat out illogical. So let's see. Yeah, yep, there you go. So yeah, the two groups would be separately. They could each have their own consolidated group, but they should not be consolidated together. The two groups should not be consolidated together. So there you go. So now we're moving on to our next topic. We spent quite a bit of time on RHC. Again, if you still have questions, feel free to type those in. The next topic is one we haven't talked about for quite some time. We have a YouTube video, we have an article out there, but we haven't really brought it up in one of the webinars. This is the Certified Registered Nurse Anesthetist, or CRNA. Now, I want to clarify this a bit. CRNA is by far the most common term used to cover this, but it's interestingly kind of backwards. The umbrella term is actually non-physician anesthetist. CRNAs are one type of non-physician anesthetist. The other one would be anesthesiology assistants. The majority of them that we see are truly CRNAs, and that term's just used. So I'm just going to continue to use that. So a little bit of history here to kind of lead up to where we are, why this pass-through payment exception even exists. Prior to 1189, the CRNA services were reimbursed at cost, even though some of those facilities, from 83 through 89 were IPPS. 84 through 89 were IPPS. It was a pass-through at that point. On and after 1189, they were converted to basically a fee schedule. In fact, the CRNA fee schedule came before the physician fee schedule, kind of interestingly. It's a different fee schedule. So on or after 1189, now CRNAs were paid fee schedule, and that was through Part B, which at the time was a carrier. Now it's a MAC. So when I say CRNA services, I want to stress here I'm talking the professional service, not the facility or technical component, which is basically the hospital services that are being provided at the same time. I'm talking the CRNA professional services. That's paid on a fee schedule. That's the general rule. So again, effective January 1, 1989, the CRNAs were forced out of that cost reimbursement and into fee schedule. The problem is with the fee schedule, just like PPS, just like the DRG-based reimbursement, it's volume-based. So if you have a small hospital that is low volume, it's just a low volume of services, if you will. We know that low volume of services means low payment for the CRNA because they're paid based on volume. If a CRNA works for a hospital and there's such low volume, if that's all the payment they get, you're going to have difficulty attracting CRNAs. And that's going to be a big problem for those small hospitals. So the CRNA pass-through provisions, the cost-based pass-through provisions, were enacted to target and help these small rural hospitals. Again, this is the main point of our discussion. Just gave a little bit of a background to lead us up to that for why it exists. As I said, there are two components. I'm going to drop to the second one, the technical component. That's going to be reimbursed on its own through the hospital. The professional component is the main topic today. By default, the professional component would be paid based on a fee schedule. But if there's an exception in place for those small, low volume hospitals, they can be paid at cost just like no, I shouldn't say that. They paid at cost, regardless of what type of facility it was. Let me put it that way. So again, you could have physicians billing for various CRNA or anesthesia services. The CRNAs could bill, and they could bill Part B for their professional component. And as I said, the hospitals would be billing Part A for the technical component. The CRNA professional right in the middle is what we're focused on today. They could bill Part B, or they could get the exception to bill as a cost-based pass-through through Part A, and it goes on the cost report. So the payment for this professional component is going to depend on a few different things. First of all, what type of provider is it? Is it an IPPS or acute care hospital or a critical access hospital? Critical access hospitals are paid cost for virtually everything. IPPSs only a few things get paid at cost. The type of setting is going to matter, inpatient versus outpatient, and the status of pass-through approval. Do they have the pass-through approval or not? Yep, I had a little, sorry about that, I had a little audio thing in there. Thought I took all those out. Little Homer Simpson for you. So professional component, and this is it's going to be paid fee schedule unless they were approved for pass-through, as I said before. Now, anytime you have anything that is fee schedule, just in general, it's going to be adjusted out of the cost report. That's, we only want the cost related to the PPS-based services. We want those in the cost report, unless, of course, it's approved for pass-through. Darn it. Sorry about that. I need to do a better job of removing those things. To adjust the costs out. So we might have situations where again, for one reason or another, we need to adjust that cost out because it was either related to the fee schedule or it was just a non-allowable cost altogether. So we could do this through A8-2 if it's a split issue, split between provider and professional, or A8 line 34 if it is a direct adjustment to CRNA costs. If it's not paid on pass-through, we need to get it out of the cost report. So now we're digging into the actual pass-through requirements here. These come from 42 CFR 412.113C. These are the pass-through requirements. Now, it's really important to read these very carefully, and I'm going to explain what each of these means. The first one's obviously pretty easy. It's located in a rural area. Now, the good thing is from 2011 and forward, that can include rural reclasses. So that benefits those providers. Here's the important thing. A hospital or CAW must have employed or contracted with a CRNA as of 1/1 of 1988. So that's never changed. That's a base year. And employed a CRNA for about a year before fee schedule came into play, and they experienced the benefit of pass-through cost. That's the whole point of this. That's why they're getting the exception. We're going to use the term hold harmless in a bit. They know what the pass-through was based on, or they set their operations up under that cost-based pass-through payment, and then CMS changed it to fee schedule. They're holding them harmless from that change. The key thing about this, though, is that any hospital that either opens up or hires their first CRNA after 1/1/88 can never qualify for CRNA pass-through. There's no rebasing of this. Like, with MDH, Medicare Dependent Hospital, there was a requirement that you had to qualify back in 1990, but then they gave a new time period or new option. There's nothing like that for CRNA. If you didn't exist, you didn't have a CRNA as of 1/1/88, you will never be able to qualify for this pass-through until and unless Congress decides to change this. So that's the first requirement. Now, a hospital or CAW may employ more than one anesthetist, but they can't have more than 28 hours total. This is something that's checked every single year, and it relates to that particular year under review. So we'll see part of the attestation when you're requesting this. You're essentially attesting prospectively that, yes, we're not going to have more than 20/80 hours. If at the time of review down the road, we find there are more than 20/80 hours, that means you lose that exception for that year that has already gone. It's already been completed. So that's a very important exception or a very important attestation. Make sure you don't go above that one FTE, that 20/80 hours. And by the way, we're going to see in just a bit, that includes all time that anesthetist is spending for the entire facility, whether it's for anesthesia related stuff or any general services. I'll point that out in just a bit here. Let's see. we have the next one is each CRNA must agree in writing not to bill on reasonable charge basis or fee schedule to the carrier. So they must agree, because that would be double payment otherwise. And once we receive that attestation, our reimbursement area also sends a notice to the Part B side deactivating that enrollment for the listed CRNAs, because that's the control to make sure that doesn't happen, essentially. There we go. And let's see. The other thing, the hospital or CAW must prove prior to that current year, or the calendar year begin, if you will, prior to the year they're trying to get the pass-through for, they have to prove that during the 1987 base year, which is 1 year prior to the 1988, and the year immediately preceding your current election year, that you did not exceed the maximum number of procedures requiring anesthesiology. Currently, that is 800. Initially it was 250, then it went up to 500. It's been 800 for quite a while now. So that's a prior year review, essentially. And you can prove it at that point that you haven't exceeded those numbers of procedures. We'll get to the detail on that just a bit here. I mentioned the hold harmless. This is just kind of going into that again. We're trying to hold the provider harmless from that change to the fee schedule, to the fee schedule. And this is a little bit of information. If you did employ a CRNA in 1988, or I'm sorry, if you did not, then there's no existing operations harmed. There's no reason to give that cost-based reimbursement. The 2080 hour requirement, the thought here is if you have more than 2080 hours of service, there must be enough services to cover the CRNA's reimbursement. So there's not that same low volume concern. So there's no reason to give an extra amount for the facility. Here's that Federal Register section I wanted to point out, though. It's in the 731.92 Federal Register. That 2080 hour limit includes the total hours of the hospital, whether services, let me go back to the hospital. Now the 800 procedure count. If there are 800 or more services, when CMS made this change in the Federal Register to the regulations, they calculated at that time that CRNA with those number of services would already be making more than the average CRNA compensation. So 800 procedures multiplied by the corresponding fee schedule would have been greater than or equal to the 2,000 average annual CRNA compensation of 141,000. Obviously, that was 23 years ago. Fee schedules have gone up. The average compensation's gone up, but CMS has not changed the procedure count limit. But that just shows why that limit exists to begin with. Now, as far as the procedures, I said the time is related to all services provided in the facility. Section of the CPT code book. Now, one question that comes up from time to time is pain management. And generally speaking, pain management doesn't have to relate to a surgical procedure. If for some reason it did, if it was under that surgical section of the CPT code book, it has to count. So as far as the eligibility, by 9/1, our reimbursement area gets a list of all these facilities that have existed that had 1988, had CRNA in 1988. We send out the election letter, and if the provider wants to apply for that year, they have to submit the data by 12/31. That's the key thing there. We already talked about the other items, the contracts and the no-bill attestations. Now, the surgical log, this is an important thing. Keep in mind, that's a the entire 12 months. So in this regulation, CMS says we'll take 9 months up through 9/30 and annualize that. You don't have to wait until 12/31. We'll use the first 9 months of that prior year and annualize it. And there's no reconciliation needed. And this is not something, by the way, that is looked at unless there's a reason to look at it. If there's a reason to believe the attestation or the data was faulty initially, there's generally no reason we would be looking at this at desk review. But again, there's still the potential if something appeared unusual. But it's not something, and we're certainly not looking for the 12 months in that next year that you had the pass-through for. We're never going to be needing the 12 months data for those procedures. The procedure count is always a prior year criterion. To qualify for this year, you have to prove that last year you were under the procedure count. Now, so again, if you failed to meet the 20/80-hour requirement during the current year, you might retroactively lose your eligibility. Or if for some reason we found that in 1988 you truly didn't have any CRNA hired, then it really should have never been approved anyways. But if we find that after the fact, then that could be a retroactive eligibility loss there. And this is just, we just have a screenshot kind of showing that line 19 is where the costs are reported. If they are approved, then we would see those costs come through. And on worksheet B, part 1, they'd be stepped down to some other cost center, commonly anesthesiology. That's what triggers the pass-through reimbursement. Now this one, the pass-through was not approved, so there were no costs on line 19 to begin with. Now, there were costs on anesthesiology. They might have been for a variety of reasons. It could have been for some other anesthesiology service, not a CRNA, but for some reason, this one still adjusted those costs out. So what that tells me is they may have been reporting their CRNA there initially, and they knew that it was not allowable for pass-through, so they self-disallowed it. But there might still be other things unrelated to CRNA in anesthesiology. And this just shows that on worksheet A8, if you were disallowing CRNA, you'd remove it through an A8 adjustment. So that takes us through our CRNA discussion. Again, it's nothing really new, just we've had a few questions over the, other type of protected hospital, also either rural, they're either the sole source of healthcare in a particular community for a variety of reasons we'll see in a bit, or they serve a significant percentage of Medicare patients, 60% specifically or above. I have the regulations that drive each of those. For sole community hospital, generally it's an isolated location. It's far from another hospital. Hence the term sole community hospital. So either you're more than 35 road miles from another hospital, or you're in a rural area and meet some other road mile requirement. There are criteria for weather and travel conditions or the absence or inaccessibility of other hospitals. Again, the idea is that a patient in any particular community should be able to fairly easily access a hospital, but some of those hospitals that are in those isolated areas, they have lower volumes, and it may be more difficult for them to operate under full DRG reimbursement. So this is a protected status. So again, if you're 35 miles or more from the nearest like hospital, it can even be an urban hospital. That's fairly rare, being both 35 miles and urban, but it's possible. But if you're anything less than 35 miles, you absolutely must be rural. And depending on the situation, there are a few other criteria you have to meet, depending on the mileage. Either you serve at least 75% of your area's admissions, whatever your service area is, you've captured the highest percentage of it, 75%, or if you have fewer than 50 beds, so you're small, and you would have met this 75% requirement, except that some inpatients needed to go elsewhere for special services that you didn't provide. You don't have the ability to provide those, then you might qualify. Or if due to topography or weather conditions, other hospitals are inaccessible, or the travel time is at least 45 minutes to another nearest hospital, then you can qualify as sole community. So generally speaking, the one we see the most commonly now, due to saturation of most communities, we generally see this 75%. That's virtually the only thing left. Again, unless you have a brand new hospital opening up in a mountainous area. But again, this 75% is the most common. So as far as the review does, or the request comes to the MAC, and we have to see whatever criteria you're qualifying under, we need to see the details for it. So if you're going with that, and again, all the mileage requirements, all of that, this is reviewed by the MAC. There is no regulatory requirement for a time frame. We send a requirement or recommendation to CMS. Again, there's no time frame. The good thing is that now CMS has changed it to be effective retroactively to the date that we receive the application. And that remains in place until it's voluntarily terminated by you, or if there's a change in circumstances where you would no longer meet those requirements. So as far as that termination, prior to 10/1/06, that was pretty vague. There was no real self-reporting requirement in place, and there was no review requirement. But in the Federal Register in 2006, CMS strengthened that, and they require providers to report within 30 days of the change if there's a new facility that opens up, if you're no longer rural, if you've changed your bed size, if that was a factor, if there are new roads that have been built that would change the time or the mileage. And if you fail to report, there's a clause in there that requires us to retroactively recoup that additional money, subject to reopening timeframes, unless, and this is the one exception to the 3-year reopening requirement period, and it's basically fraud. If there was some proof that there was a fraudulent SCH treatment, then that can go even further back than 3 years. That's the other thing about that. So of course, if you find out about this situation, it's best to voluntarily terminate so that you don't have a recoupment, have a extra money that now you have to figure out how to pay back. And if you, let's say you had to voluntarily terminate, but then maybe later on you requalify for some reason, maybe that hospital is closed down or the road miles have changed again, you have to wait at least 1 full year. And of course, you have to meet the new qualifying SCH criteria. For MDHs, this was never intended to be permanent, but it's been extended currently all the way through 9/30 of 2024. You have to be rural, under 100 beds. You can't already be an SCH. And honestly, if you were, you wouldn't want to be an MDH anyways. SCH is more beneficial. And the big thing here is that you have to have more than 60% of your total patients that are Medicare, either through days or discharges, and that includes HMO Part C. Now, that 60% test was initially done in 1987. However, if you didn't meet it in 1987, now you have the option from 2001 forward through current to look at the last two of the last 3 finalized years to make sure you've met it in 2 of those 3 years. They don't have to be consecutive. It could be year 1 and year 3, whatever. And again, it's either days or discharges. Very similar to the application for SCH, you must file it to the MAC, show the documentation. Now, this one, we do have to review it within 45 days, and we make a recommendation to CMS, and they respond within 30 days. But again, the status change is retroactive to the date we received the application anyways. We reprocess the claims. All is good there. For termination, so again, if you lose your rural status, change your bed size, that could terminate the MDH status. But during the COVID period, the public health emergency, there were a variety of waivers in place for different types of special treatments, and MDH was one of them. For those years covered by the COVID PHE period, none of those years will ever be used to terminate MDH for a future year. So what that essentially means is MDHs will not lose their status until at least 2 full cost report periods have been finalized after the COVID PHE period. That I should say that began after the COVID PHE period and were finalized. That's the earliest that you would lose your status. So that's the one thing I wanted to mention there. So that's the way that waiver was kind of put in place. Now, as far as the hospital-specific payments, the entire purpose of being in SCH or MDH is that you get only get 75% of the extra difference. For soul communities, it's just the higher of the two altogether. But the point is, you'll never be hurt by being a soul community or a Medicare Dependent Hospital. You'll always get more than just the federal payment, or you'll never get less than the federal payment. Let's put it that way. So whether you're using the federal rate or the hospital-specific rate, they're both per discharge, and it's multiplied by the DRG weights on the PSNR. And I want to stress that is the DRG or CMG weight. That's what's used for the calculation. It's not just the discharges, it's the DRG weight. Again, here's the slight difference between SCH and MDH. Now, the point I wanted to make here with the last couple minutes we have is that factor. Now, in the pricer, what we call the provider specific file, we don't update the rate every single year because the pricer itself knows when that rate was last updated, and it knows what factors you need to get to the current year in question. So they didn't tell us we needed to update the rate every year because pricer does it for us. Now that pricer can only, and I just say remember, in the system, for whatever reason, it only allows us to go about 6 years before we have to re-inflate that rate and put a new rate in the pricer. Now, every 6 years, there's going to be either a rebase or just a new, raising it to a new level. And then the pricer will take over from that point on to the current year. So what I wanted to show here is just a screenshot of our hospital-specific payment calculation that we use at final settlement. We use this, we send it out to providers if they question it, if they want this information. But you put in whatever service dates you're looking for. You need to know whether you qualified for the quality indicator and whether you were subject to the EHR reduction. But then this line right here is the last rate that we inflated to, the last time we updated Pricer. And then again, Pricer takes over. By the way, this would have been a 10/1/18 rate, and we had to inflate it to 10/1/22. That's what these update factors are for. So that 58.88 is the inflated version of 54.23. That takes us to 10/1/22. You multiply that by the DRG weight from the PSNR to get your actual hospital-specific payments. What I wanted to mention here is that I will actually be sending this, or I'll be posting this, a version of this calculation to our annual rate section of the website. There are some changes I need to make. We have to have an ADA compliant version of this, and that's kind of causing some difficulty converting this to an ADA version. So I'll make sure to get that out as soon as I can, and we'll let everybody know about that. This is just a list of all the different times that we had to either rebase or inflate. Again, it's approximately every 6 years, sometimes less. The last time was 10/1/18, so it's very likely in this next year that CMS will be telling us we need to either rebase or inflate, whichever one they decide to do. This just shows really quickly how the calculation is done on the cost report. Line 48 is where the hospital-specific payments are reported. They're compared with the federal payments, and for a sole community hospital, you get the higher of the two. And Sue, you have a good question there. Does the COVID PHE exception for MDHs also apply to sole community hospitals? And the answer there is no, it would not, because there's nothing really in a specific year. There's no reason to believe that COVID would have led to a change in how that cost report was structured that would impact the sole community hospital. For example, with the MDH, due to COVID, you couldn't manage it. You had to take whatever patients were really coming in. You didn't have the ability to manage that 60% Medicare. You might have had a lot of non-Medicare that you normally wouldn't have. So that could have impacted your qualification. But for sole so that's why there's no COVID exception for that. Good question, though. So with the last couple minutes we have, I just wanted to point out we have our new audit rate or claim information page. Now this kind of shows you the redesign of the cost or the website, but it's labeled annual rate information. And here's the link to it. Just wanted to show you that. We talked about it a little bit last time. And then as always, I just wanted to walk you quickly through some links we have. This is to our WPS website itself, the audit section. This link is to our YouTube audit playlist. And then the next few slides are just a listing of all the different training videos we've had out on YouTube. Obviously, at some point, I'm going to have to kind of cut this off, but I just wanted to show you, how many we had so far, just different ones we've had. As it grows, it kind of becomes meaningless to keep including it there. A little bit of information on YouTube videos that we have planned for the future. We just talked about the RHC rates and consolidation. Once we get that final CMS clarification, my goal is to put out another YouTube video on that. There's one I've been holding on to for a while. I wanted to put one talking about some of the requirements that we have for desk reviews and audit, some of the documentation type requirements. That's one I've been trying to build up and get as much in as I can. So that's still pending. And then for those facilities that it's applicable for, organ acquisition, we're going to be we're doing some internal training right now, and I'm going to put some external YouTube video training on organ acquisition issues. Just a reminder of the different webinars, and we will have one in February or March, probably a two-parter that's S10 specific. And with a minute right before the hour, just wanted to remind everybody of the survey link. If you have a chance to fill that out, I'm going to post it one more time in since it got buried a little bit early on. But I certainly appreciate if you could take a few minutes to do that, to give us some feedback. Again, if you're from a MAC, whether it be WPS or any MAC, please do not take the survey. That's not for MAC staff. It's only for providers, consultants, and others. But again, I thank you very much for your time. Are there any final questions before we wrap up here? Okay, and again, I will be sending out an email later this week with all this information. But I thank you very much for your time. Hopefully this has been beneficial to you, and have a great day and great holidays for the rest of the year. Thank you.